Thank you for joining us for the 4th Annual Global Summit on Kidney Innovation, Global Kidney Patient Voice, the key to accelerating innovation, a collaborative partnership event presented by the American Association of Kidney Patients, the George Washington University School of Medicine and Health Science. My name is Dale Rogers, and I'm an AAKP Board of Director and member of the AAKP Executive Committee and an AAKP Field Ambassador for the state of Idaho. I'm also a kidney patient. I have experienced hemodialysis, peritoneal dialysis, and am a current kidney transplant recipient. 6+ years out, and I also received a pancreas transplant. Diagnosed at 12 years old with type 1 juvenile onset diabetes and later hypertension, the two leading causes of kidney failure today. Advocating exclusively with AAKP with Advocacy Hill Days, participating in advisory boards for industry to provide unique patient insights, and representing AAKP in various federal agencies and also on the SRTR Patient Family Advisory Council to help patients better understand the choices they can make with the transplant centers. Being part of AAKP allows me to share my patient voice in situations where patient outcomes is not always the main topic of conversation. As an AAKP member, you can also do the same. This is critical now that we, as patients, consumers, raise our voices and create the demand for new diagnostics, devices, and biologics in our independent countries. Through AAKP Global, launched in 2019, AAKP is engaged internationally because we are committed to educating patients and leaders across the globe on the importance of kidney disease prevention, new innovations in treatment, and the opportunity to save more lives. We believe that a united patient voice can drive innovation and the policies decisions that determine timely regulations and payments for new and safe care treatments. Globally, we are working with patients, medical professionals, researchers, and medical industry allies to cultivate a united consortium led by patients. AAKP believes this international consortium can advance innovation and change kidney care in countries where healthcare systems and/or infrastructure do not support patients, consumer choice, and/or access to care treatments. For our session, The Future is Here, the Decade of the Kidney and Artificial Organ Innovations in Alternatives to Dialysis. I am now pleased to introduce friend and ally to AAKP, Dr. Buddy Ratner. Dr. Ratner is co-director of the Center of Dialysis Innovations, director of the Engineered Biomaterial Engineering Research Center, Michael L. and Myrna Darland Endowed Chair in Technology, Commercialization, and the Professor in Bioengineering and Chemical Engineering at the University of Washington. He joins us today to share the latest in the Centers for Dialysis Innovations, Ambulatory Kidney to Increase Vitality Innovation, which is an artificial kidney system. Dr. Ratner co-directors the Center for Dialysis Innovations with another good friend of AAKP's, Dr. Jonathan Himmelfarb. Under their direction, their research team has received 3 Kidney X awards for this innovation. Dr. Ratner, thank you for joining us today. I turn it over to you.
Greetings. It is a great pleasure and honor to be invited by the American Association of Kidney Patients to present to you some new ideas in this theme of accelerating and transforming innovation. I believe you will see some work that particularly comes from the University of Washington Center for Dialysis Innovation that indeed talks to transforming the patient experience, let's say positively transforming the patient experience and definitely improving outcomes. In one slide, I tried to summarize what we're trying to do here and what our Center for Dialysis Innovation at the University of Washington is trying to do. Hemodialysis today is complex, technologically demanding, and we'll go into some of the reasons why I think it needs updating. But to the right, look at that vision. You're sitting comfortably on your couch. You're connected to a dialyzer. You can wear it out. That's the vision. That's not here yet, but you'll see how we're well on a path to getting there. There will be at least work from at least 2 companies mentioned, and I thought just for full disclosure, I should mention that I've been involved with these 2 companies. So hemodialysis today is what I'd like to call a defective therapy. As patients out there, many of you are on hemodialysis, but so I don't think the items on this slide are going to come as much of a surprise. But hemodialysis is painful, unpleasant, complication-ridden. The average lifespan of patients starting hemodialysis is much too short. Hemodialysis is an environmental disaster with water usage, medical waste. We'll go over that. It's a very expensive technology given how many problems it has. And there's been little game-changing innovation since it was invented. We'll talk a little bit about the history. And I always found extremely compelling this figure. And there's an estimated maybe 2 to 7 million people worldwide with end-stage kidney disease that simply died without access to chronic dialysis. Maybe some new forms of dialysis can address that international tragedy too. So what are the patient concerns? And again, I'm obviously talking to the converted. The patients all understand this, but we have our own patient advisory group. I'll mention that. And blood access needles are one of the biggest concerns, one of the most negative aspects of hemodialysis. The often extreme dietary restrictions reduce quality of life. There are travel and lifestyle restrictions due to dialysis sessions. People are feeling poorly after dialysis. You'd think dialysis would make you feel well, but in fact, there are a lot of complications. And then finally, if you want to do home dialysis, certainly safer, many extents than going into a dialysis center, the replumbing and medicalization of the home for home dialysis is a big problem. This is a photograph, the picture on the left of Dr. Willem Kolff. That I took this photograph when he was 92. I had the great honor and pleasure of knowing Dr. Kolff. And in the right is an image of the kidney dialyzer he invented that transformed kidney dialysis. If you read the little caption at the top, he did it under rather crude conditions during World War II. But the picture at the bottom, the black and white picture, is Mrs. Sophie Schaffstadt, and she was probably the first kidney dialysis patient, the first person ever brought out of a uremic coma by dialysis. In this very brief history, these are probably the next pioneers. Dr. Kolff could do acute dialysis, but not chronic, couldn't keep a patient going. And these three individuals, Les Babb, a chemical engineer, Belding Scribner, an MD nephrologist, Wayne Quinton, a bioengineer, built the first kidney dialysis systems as we know them today. And that was a collaboration between physicians and engineers, which led to a therapy sustaining life for well over 4 million people each year worldwide. Wayne Quinton and Belding Scribner developed this shunt that allowed access to the patient's blood. That was one of the great innovations that they developed. This is the first patient who was chronically dialyzed, Clyde Shields at the University of Washington Medical Center. And to tell you the truth, the equipment looks a little different. It was very crude in 1960, but basically he is being treated in a manner similar to what we do today. There are no conceptual advances. He's being dialyzed against a large volume of water, and that's what we do today. These efforts, I was very pleased to be in Seattle because this is really the home of kidney dialysis. And in 1962, Dr. Belding Scribner realized the need for dialysis centers. This is the plaque representing the site where the world's first artificial kidney center in Seattle was opened. So some 60 years or so have passed since these pioneering efforts. Where are we? Starting about 2000 or so, I think we started using hollow fiber dialyzers. We started using kidney dialysis machines that look a bit like they look today. And as I say, this is quite similar to what we were doing in 1960. One of the issues with what we're doing, maybe not so often addressed, is the environmental impact, which I consider not sustainable. We use an incredible volume of water, maybe a cube of water each year as high as the Petronas Towers, a gigantic volume of water, of good quality water, a huge amount of electricity and giant amounts of medical waste produced. In fact, we use enough PVC tubing in just hemodialysis alone to go from the Earth to the moon and back 3.5 times. That's how much tubing we chuck into the waste each year. So we can lament the poor situation for kidney dialysis, environmentally unfriendly, maybe unfriendly to the patients, not that successful. But we can do something about it. In the left on this slide, you can see my colleague and co-director of our Center for Dialysis Innovation, Professor Jonathan Himmelfarb. In the center is Dr. Gura, the inventor of a wearable kidney. At the right is Professor Larry Kessler, who's in our School of Public Health and worked on this clinical trial that was held in the University of Washington 2015 on a wearable kidney dialysis. And you can see this device on a patient. This young lady is thrilled to have the device. Such devices get huge respect, enthusiasm from kidney patients. However, this device never went on further. The clinical trial that was happening at the University of Washington was discontinued over key issues in patient safety. And but that clinical trial was an inspiration. That clinical trial led us to launch our Center for Dialysis Innovation. Could we do such a wearable better? And this is a collaboration between physicians and engineers, just as the original dialysis was between MD Belding Scribner and engineers. Here we have another collaboration focused on bringing us to true portable and wearable dialysis. So one of our thinkings is your kidneys work 24/7. How can we expect 3-4 hour dialysis treatments a week to emulate the natural kidney? We can't. How we can get longer, more continuous dialysis to emulate how your kidneys work? So our vision is to develop a device, we call it the ACTIVE, the ambulatory kidney to increase vitality is ACTIVE. And our generation 1 would be a portable device, and generation 2 would be a wearable. It'd be miniaturized, water efficient, let's say more environmentally friendly, greener, minimal anticoagulation, robust design, cost effective, patient centered, and could restore kidney health. Again, these are our visionary solutions. They're not here yet. So in order to do a thing like this, there's a lot of different pieces of the puzzle that have to go together. And we have to address every single one of these. We have to remove toxins. We need a way to continually monitor what's going on, sensors and measurements, because there won't be a dialysis nurse with the patient all the time. We have to worry about infection, bacteria, and biofilms. The issue of blood access, we've mentioned. Patients want better blood access. We have to make sure the device doesn't clot within its tubing and flow paths, better blood compatibility. And then there's a lot of device design and engineering, human factors that have to go into it. It has to be translated from the laboratory to commercialization. And these are all aspects we are thinking about at our Center for Dialysis Innovation, CDI. So one of our, what we call our breakthrough technologies is what we call the POR unit, the photo oxidation of urea unit. What we're doing, you can see the patient to the left. We take the patient's blood, put it into ordinary dialysis. Hollow fiber dialyzer goes back into the patient. And out from the dialyzer comes the urea, which goes into that, you can see those green things on the right. What those are is a catalyst that breaks down the urea to nitrogen and CO2 and then pumps back regenerated or fresh dialysate into the dialyzer to keep on removing more urea from your body. At the moment, we use about 120 liters of high quality water in each dialysis session, weighs 120 kilograms, maybe 270 pounds water. Can't carry that on your back. You need a big water system, pictured on the bottom, to make all that high quality water. In the right, we're going to do it with 1 liter of water because we take the urea, we don't have to flush the water with urea down the drain. We take the urea and make it into nitrogen and CO2, harmless atmospheric gases. So this is some science. The diagram at the right shows the experiment. What we do is we have a big tank. We're pumping into this tank urea at the rate your body makes it, roughly. And with the UV lights of the dialysis regeneration module, the POR unit, out, that's the red line on the left. The urea concentration increases because we're pumping more urea into the tank. On the other hand, if we have our dialysis regeneration module, the POR unit, the lights turned on, which catalyzes the breakdown of urea, the urea level remains constant, and in fact at a level that is normal in blood rather than building up in blood. And we also get rid of some other toxins too. That's the diagram on the right. But I don't have time to go into all those details. So this is a very complicated slide, and I do not have time in this very short talk to go into this. This is shows that we can treat the tubing and other components of the device to give very low blood platelet activation and very low coagulation. In other words, we need much less anticoagulant, maybe a baby aspirin instead of heparin in our system. So some of the challenges addressed by the ACTIVE, the ambulatory kidney, it'll have lower costs, will be needle-free blood access, longer lasting components, reduced medical waste, longer dialysis sessions. The longer the dialysis, the better you feel, reduced infection and biofilms, and there'll be sensors and monitoring. With this issue of painful needles and the problems associated with blood access, we at the Center for Dialysis Innovation have developed what we're calling the active connection. And this will be truly painful. Hemodialysis blood acts as needleless, touchless, resists clotting, resists and prevents infection, and will truly facilitate, allow home dialysis. The patient just plugs in, plugs out, self-sterilizing with very few steps that the patient has to address to do this. One of the ultimate challenges is, hey, we're developing all this at the University of Washington. We're excited about it. How do we get from a university development to patients? We have spun out a company that is totally focused on doing this, on translating the developments from the university to patients. The company is called Kuleana Technology. Kuleana is a Hawaiian word meaning responsibility and care. And that's what we think about too, in taking these developments and commercializing them for patients. So Kuleana Technology is hard at work taking some of the developments you've seen and bringing them to patients. Importantly, in our Center for Dialysis Innovation, we have the patient's voice is extremely important. We have patients engaged in all aspects of our Center for Dialysis Innovation, patient panels, a very active patient advisory group. If the patients won't embrace what we're doing, we'll never succeed, and we are focused on success. So I'm going to end up here with this quote from Belding Scribner, the visionary nephrologist who brought kidney dialysis to us, saved millions of lives, winner of the Lasker Prize in Medicine. Belding Scribner said in 1963, if the treatment of chronic uremia cannot fully rehabilitate the patient, the treatment is inadequate. Well, here we are in 2022, and that quote is still accurate. And our Center for Dialysis Innovation is trying to do something about that. Well, it's been a pleasure and honor to present to you the innovations coming from the University of Washington Center for Dialysis Innovation. We embrace the feedback of patients, and we'd be glad to interact with you. I'm very easy to contact by email, ratner@uw.edu, very simple email address, and we'd be pleased to have a dialogue and to embrace your feedback and your thoughts. Again, thank you.
Thank you, Dr. Ratner, for the wonderful presentation and for your and your team's commitment to change status quo, kidney care by innovating beyond dialysis.